If you have hypermobile Ehlers-Danlos Syndrome, well, you already know your body is a bit unpredictable.
Oh, absolutely.
You might even be one of the people who waited, what is it, an average of 10 years just to get a diagnosis?
Yeah, a decade is unfortunately the standard for so many.
Right. But what happens when you throw the hormonal shifts of menopause into that mix? Why do, 61% of people with hEDS report that their joints just suddenly fail them?
It's a massive, severe worsening of joint laxity and pain.
Exactly. The moment they hit the menopause transition, it just falls apart. And that is exactly what we're answering in our deep dive today.
It's a really fascinating mystery to unpack.
It is. And we've got a great stack of sources for this. We're looking at deep dive medical scoping reviews on the hormone relaxin. We have the latest clinical guidelines for hEDS and some really extensive epidemiological data on menopausal arthralgia.
Right, so we have a really solid scientific foundation to work from.
We do. Our mission today is to take this seemingly bizarre correlation and map out the actual underlying biology for you. So where do we even start?
Well, to understand the sheer scale of the havoc that menopause wreaks, we actually have to establish the baseline. We have to look at what a hypermobile body is doing during its reproductive years.
Okay, let's lay that foundation.
So it's a baseline that relies on a very, very fragile structural foundation.
Right, because at its core, hEDS is a connective tissue disorder, right? It's driven by faulty collagen.
Exactly.
If we think of collagen as the primary biological glue that holds the human skeleton together,
Yeah.
forming the tendons, the ligaments, the fascia, the skin, someone with hEDS is basically operating with glue that's inherently defective.
It's just too stretchy.
Right. The ligaments, which are supposed to act like strong, taut bungee cords stabilizing your joints,
Yeah.
they're already totally slack.
And operating in that slackened state requires this delicate, lifelong calibration just to function. Now, during a person's reproductive years, the dominant hormonal player in this environment is estrogen. Okay.
And estrogen has a highly complex dual role when it comes to connective tissue. On one hand, it actually stimulates fibroblasts to produce more collagen.
Oh, so it encourages the synthesis of new tissue,
Exactly.
which, I mean, on the surface, that sounds really beneficial. If your structural glue is faulty, you would seemingly want your body manufacturing as much of it as possible.
You would think so, yeah.
Yeah.
But estrogen also decreases the stiffness and structural integrity of those ligaments.
Wait, how does it do that if it's making more collagen?
It achieves this by actively inhibiting a very specific enzyme called lysyl oxidase, or LOX for short. Okay, let's zoom in on that mechanism because this LOX enzyme seems pretty central to the problem. What is it actually doing at a cellular level?
So LOX is an extracellular enzyme, and it's responsible for creating the structural scaffolding of the tissue. Once your body produces collagen fibers, they are essentially just loose threads. They don't have strength yet. LOX comes in and oxidizes specific amino acids on those threads to form chemical bridges, basically cross-links between the collagen molecules.
Oh, wow. So it's tying them together.
Exactly. This cross-linking is what gives a ligament its tensile strength and stiffness. It takes those loose threads and weaves them into a dense, load-bearing rope.
And estrogen just shuts that whole process down.
It suppresses it significantly. Research indicates that when estrogen peaks naturally during the menstrual cycle, specifically, in the late follicular phase, right before ovulation, LOX activity can drop by as much as 77%.
77%. That is a huge drop.
It's massive. So the body might be producing new collagen, but that collagen isn't being tied together securely.
So the ligaments become looser and, I guess, dramatically more vulnerable to injury.
Exactly. And the sports medicine data reflects this perfectly. Studies tracking female athletes consistently show a significantly higher rate of ACL tears during that precise high estrogen phase of their cycle.
Right, because the structural integrity of the knee joint is temporarily compromised by the hormonal environment.
You got it.
Okay, but my logical brain is flagging something here. Let me just unpack this.
Sure.
If high estrogen equals inhibited LOX, which results in loose, unstable ligaments, shouldn't the onset of menopause actually fix the problem? Right? I mean, menopause is defined by a permanent, massive drop in estrogen. If estrogen is the variable making the joints dangerously loose, taking it away should theoretically stiffen the connective tissue and make an hEDS patient more stable. Why are 61% of patients feeling more unstable? Make it make sense.
That is such a good question, and it's the exact logical trap that frustrates patients and, frankly, confounds a lot of general practitioners.
Because it seems completely contradictory.
It does, until you separate the concept of menopause into two entirely distinct physiological events. There is the journey, which is the transition phase, or perimenopause, and then there is the destination, which is postmenopause. And they inflict completely different types of mechanical stress on the body.
Okay, so let's start with the journey, the transition phase. Perimenopause is generally, what, a 4 to 10 year window?
Yeah, roughly. And the medical literature increasingly refers to it as a neurological transition state.
Because estrogen doesn't just execute this smooth, gradual glide path down to zero.
Not at all. It's a chaotic roller coaster. The brain-ovary feedback loop essentially starts misfiring.
Oh, wow.
So from cycle to cycle, estrogen spikes violently to levels much higher than normal, and then it crashes abruptly to near zero.
And for a hypermobile body that has spent decades carefully calibrating its movement patterns to a predictable monthly rhythm, this chaos just destroys that calibration.
It completely shatters it. But estrogen isn't acting in a vacuum during this transition either.
Right. The sources point to two other hormones fundamentally altering the connective tissue matrix here, progesterone and relaxin.
Yes. So relaxin is a peptide hormone, mostly famous for its role in pregnancy, where it physically remodels the pelvic ligaments to allow for childbirth.
Makes sense.
But the ovaries produce relaxin throughout the normal menstrual cycle as well, and it operates by activating matrix metalloproteinases, or MMPs.
Okay, MMPs, those are the enzymes responsible for tissue remodeling, right?
Specifically, relaxin activates MMP9. You can think of MMP9 as a pair of nanoscale molecular scissors.
Scissors.
Yeah, its primary function is to literally degrade collagen and gelatin. It dissolves the extracellular matrix to increase tissue elasticity.
Oh my gosh. So in a patient with hEDS, relaxin is actively dissolving what little structural integrity their faulty ligaments have left.
Yes, and here is where progesterone enters the equation. Progesterone physically alters the connective tissue to make it more receptive to that dissolving action.
Wait, really?
Yeah, it upregulates relaxin receptors.
So it's essentially building more docking stations on the ligaments.
Exactly. It doesn't just matter how much relaxin is circulating in the bloodstream. Progesterone is determining how aggressively the ligaments capture and respond to it.
Okay, so if we visualize this biomechanically, it's like driving a car with a fundamentally broken suspension system. That's your baseline hEDS experience.
That's a great way to put it.
Over the years, you learn how to drive it. You memorize the exact location and depth of every pothole on your commute, and your brain subconsciously learns how to brace the steering wheel before you hit them.
Right.
But perimenopause is like someone randomly changing the layout of the road every single day.
Yeah.
One day the suspension is dangerously loose, the next it's rigid, and the gravity inside the car is fluctuating.
Yes.
You can't brace for the impact because the physical parameters of your joints are changing faster than your nervous system can possibly adapt.
It creates profound mechanical instability. The nervous system is constantly trying to establish a safe range of motion, and the hormones just keep moving the goalposts.
Which is why the perimenopausal transition is frequently documented as the most physically traumatic and painful phase for an HEDS patient.
Precisely.
Okay, but eventually that transition does end. The roller coaster stops, the brain-ovary loop shuts down, the spikes cease, and the patient enters full post-menopause.
Right, the destination.
Estrogen and progesterone flatline.
Yeah.
The wild fluctuations stop. So we return to that original puzzle.
Why doesn't the mechanical instability resolve at this point?
Because now the body is dealing with a severe lack of resources. It transitions from a state of chaotic signaling to profound depletion.
Okay, break that down for me.
Once estrogen is permanently low, yes, the body does lose that LOX inhibition we discussed earlier. The cross-linking process is no longer being suppressed.
Okay, so the threads can be woven together again.
Yes, but it also permanently loses estrogen's ability to stimulate the fibroblasts to synthesize new collagen.
Oh, so the body stops manufacturing new glue entirely.
Exactly. It can't replace the tissue that those MMP9 scissors were degrading for the past decade.
That is brutal. And it gets worse. Estrogen plays a critical role in tissue hydration. It promotes the production of hyaluronic acid, which binds water in the extracellular matrix.
So without estrogen, the connective tissues lose their ability to retain moisture.
Right. The synovial fluid that lubricates the joints decreases in volume and viscosity. The tissues literally dry out.
And this is what the sources refer to as menopausal arthralgia, right?
Yes. The tendons and ligaments transition from being loose and hyperelastic to becoming stiff, brittle, and highly susceptible to micro-tearing and chronic inflammation.
Wow. So if you are living through this transition right now, you are experiencing just a brutal shift. Your joints are still fundamentally hypermobile due to the underlying hEDS, but the tissues trying to hold those joints together have become dehydrated and friable.
Exactly. It's a terrible combination.
What are the actual physical symptoms you're waking up with at that point?
Well, we see a massive surge in conditions like adhesive capsulitis, which is commonly known as frozen shoulder, where the joint capsule becomes severely inflamed, thickens, and physically adheres to itself.
Ouch.
We also see widespread gluteal tendinopathy, which is the painful breakdown of the tendons attaching the gluteal muscles to the hip bone, and chronic intractable Achilles tendonitis.
Because the connective tissue is failing under loads it used to be able to manage?
Right.
Which brings us to a really crucial missing piece of the puzzle. If the ligaments and tendons are completely failing because of this lack of estrogen and hydration, the hEDS body must have to rely almost entirely on its musculature to hold the skeleton together.
It does. The muscles have to act as the primary scaffolding.
But menopause heavily impacts muscle mass as well, doesn't it? Primarily through a hormone we haven't even discussed yet.
Testosterone.
Yes. The medical literature frequently refers to testosterone as the forgotten hormone in female physiology.
I think a lot of people forget women even produce it.
Right. But women produce testosterone primarily in the ovaries and the adrenal glands, and it is a vital anabolic hormone for the musculoskeletal system.
What does it do exactly? It binds to androgen receptors directly within muscle tissue, promoting protein synthesis and increasing the stiffness and load-bearing capacity of tendons.
Okay, but as a woman ages and transitions through menopause, that ovarian testosterone production drops significantly.
It drops, and the cellular mechanism here is critical. When testosterone levels fall, the stimulation of those androgen receptors decreases.
So the balance shifts.
Exactly. Protein degradation begins to outpace protein synthesis. The result is progressive atrophy of the muscle fibers. The muscle mass actively shrinks and loses its contractile strength.
Oh man, that is the ultimate biological trap for someone with hEDS.
It really is.
Because they are relying on their muscles to do the job their faulty, brittle ligaments can no longer do. And right at the exact moment their connective tissue dries out and becomes inflamed, the drop in testosterone is actively dismantling their muscular scaffolding.
They are losing the one compensatory mechanism keeping their joints from dislocating. It is a devastating sequence of events.
I mean, the structural failure is comprehensive. It spans the ligaments, the tendons, and the muscular support system.
Yes, which is why it's so important to emphasize it is not just aging.
And it is certainly not a psychosomatic manifestation of anxiety, which is, unfortunately, how it is often dismissed in clinical settings.
Too often, yeah.
Okay, so having mapped out this biological perfect storm, we have to look at the solutions. If the core problem is a cascading failure caused by the loss of estrogen, progesterone, and testosterone, the logical intervention seems to be putting those hormones back.
Right. We need to examine hormone replacement therapy, or HRT.
MHT, HRT, yeah. So what's the latest on that?
The systemic hormone replacement is the frontline consideration, and the landscape surrounding it has evolved dramatically. In November 2025, the FDA actually updated its safety labeling for HRT.
Oh, right. They removed the long-standing black box warnings regarding cardiovascular disease and dementia for women who initiate therapy within 10 years of menopause onset.
Exactly. This was a monumental acknowledgement by the regulatory bodies that the systemic benefits of estrogen, particularly for musculoskeletal and neurological health, heavily outweigh the risks for the majority of the population.
That shift in the clinical consensus is huge. But parsing through the clinical guidelines for hEDS specifically, there is a glaring void, isn't there?
There is. There are absolutely no specific randomized controlled trials evaluating the efficacy or safety of HRT specifically in the HEDS population.
None.
None. It requires taking generalized data and carefully applying it to a hypermobile physiology. It necessitates a highly cautious, individualized approach.
Because it's not just a magic bullet.
Right. For many patients, replacing estrogen effectively smooths out the erratic spikes and crashes of the perimenopausal transition. It rehydrates the tissues and stimulates baseline collagen production, mitigating that menopausal arthralgia.
But there is a biological catch regarding the progesterone component, right?
Yes. If a patient still has their uterus, progesterone is clinically required alongside estrogen to prevent the overgrowth of the uterine lining.
But as we established earlier, progesterone upregulates relaxin receptors.
Exactly. Introducing exogenous progesterone can sometimes artificially recreate that perimenopausal joint laxity.
The ligaments become hypersensitive again.
Right. So physicians often have to experiment extensively with different types of progestins or highly localized delivery methods like intrauterine devices to protect the uterus without triggering systemic joint instability.
Wow. Okay. And the delivery method of the estrogen itself is equally critical, especially when we look at the comorbidities associated with hEDS.
Yes, delivery method matters incredibly.
I want to highlight the Key Research BMJ 2019 study from our sources here. This was a massive nested case control study, analyzing the real-world GP records of over 80,000 women.
The data from that specific cohort is foundational for managing complex patients. They isolated the risk profiles based on exactly how the estrogen was administered.
And what do they find?
They found that taking oral HRT, so swallowing a pill, increased the risk of venous thromboembolism, which are dangerous blood clots in the deep veins, by 58%.
58%. Okay, we need to explain why that happens, because it directly impacts the hEDS community.
Sure.
When you take estrogen orally, it goes through the stomach and hits the liver first, right? This is called first-pass metabolism.
All right.
So the liver processes the estrogen, but in doing so, it synthesizes coagulation proteins like factor VII. It actively thickens the blood.
Exactly.
Now, for an average person, this is a risk, but a vast number of people with hEDS also suffer from POTS, postural orthostatic tachycardia syndrome.
And POTS is a form of dysautonomia where the autonomic nervous system struggles to regulate vascular tone.
Meaning the blood vessels don't constrict efficiently when the person stands up, causing blood to pool in the lower extremities.
Right.
So if you have poor vascular tone and gravity is already causing blood to pool in your legs, the absolute last thing you want to do is introduce an oral medication that tells your liver to pump out clotting factors.
The risk of a deep vein thrombosis becomes a massive liability.
Which is why the alternative delivery method is paramount. The same BMJ study confirmed that transdermal HRT, delivering the estrogen across the skin barrier via patches, gels, or sprays, carries zero increased risk of venous thromboembolism.
Zero. Because transdermal application bypasses the liver's first-pass metabolism entirely.
It goes right into the blood.
Exactly. The estrogen enters the bloodstream directly without triggering the coagulation cascade. So for an hEDS patient, particularly one with comorbid POTS or vascular vulnerabilities, transdermal is the scientifically backed, absolute non-negotiable route.
Okay, that makes total sense. Now, beyond systemic HRT, the sources outline some highly targeted, localized interventions too.
Yes, especially for the pelvic floor.
Right. When we look at the loss of tissue integrity, the pelvic floor is frequently compromised. It's essentially a complex hammock of connective tissue. And our sources indicate a high prevalence of pelvic organ prolapse in the hEDS community during menopause.
And addressing that requires localized vaginal estrogen, which restores the tissue architecture locally without heavily affecting systemic hormone levels.
It rehabilitates the collagen matrix specifically where it's failing structurally.
Exactly. But hormonal interventions alone cannot reverse the loss of the muscular scaffolding.
Ah, right. We established that the drop in testosterone causes muscle fiber atrophy. If you can't rely on endogenous testosterone to maintain the muscle, you have to force the muscle to adapt through mechanical stress.
Which means the clinical guidelines stress that resistance training is not optional for this population.
It's a biological imperative.
Yes, but it must be paired with intensive proprioception training.
Proprioception. That's your central nervous system's awareness of where your body is in three-dimensional space, right?
Right. It relies on mechanoreceptors and muscle spindle cells located within the joints and ligaments to send signals to the brain. But in hEDS, because the ligaments are loose and damaged, those signaling pathways are heavily compromised.
The brain literally loses track of the joint.
It really does. Neuromuscular control deteriorates, so the rehabilitation cannot just be about lifting heavy weights to build mass.
What does it need to be?
It has to be about training the brain to recruit those specific muscle fibers instantly to stabilize a joint before it subluxates.
Wow.
It requires highly specific guided physical therapy focused on isometric holds, slow eccentrics, and joint position sense. You are actively rewiring the nervous system to compensate for the hormonal muscle loss.
So, if a listener is sitting in a specialist's office tomorrow, the blueprint is pretty clear. What's the main takeaway they should advocate for?
They need to advocate for a highly individualized transdermal hormone protocol to bypass the liver and manage the joint dehydration. They need careful management of progesterone to prevent relaxin hypersensitivity.
And a referral to a physical therapist who actually understands how to train proprioception in a hypermobile body.
Furthermore, they must seek out a menopause specialist who comprehends the nuances of connective tissue disorders. A standard clinical protocol designed for a structurally typical body will absolutely fail an hEDS patient.
Okay, let's pull all these threads together. We mapped out a remarkably complex biological cascade today.
We really did.
We started with the estrogen paradox, observing how it stimulates collagen synthesis while simultaneously suppressing the LOX enzyme, preventing the crucial cross-linking that gives ligaments their strength.
Then we tracked the chaos of the perimenopausal transition.
Right, where erratic spikes in progesterone upregulate relaxin receptors, allowing those MMP9 scissors to systematically degrade the extracellular matrix.
And then we explored the postmenopausal aftermath. The cessation of estrogen production leads to severe tissue dehydration and menopausal arthralgia, transforming the ligaments into stiff, friable structures.
And finally, we uncovered the hidden impact of dropping testosterone levels, which actively dismantles the muscular scaffolding that the hEDS body relies on for structural survival.
It is an overwhelming sequence of physiological events.
It really is. So to our listeners, if you have been sitting in a clinic in intense pain, struggling to articulate why your body suddenly feels like it is failing, the science validates your experience.
Completely.
It is mechanical failure, and it is entirely driven by endocrinology. It's not all in your head.
The biology confirms it. But before we wrap up, there is one final unexplored thread in the current medical research that I want to leave the listener to chew on.
Oh, okay. Let's hear it.
So our discussion today focused strictly on the musculoskeletal system, right?
Right. Joints, ligaments, muscles.
However, the immune system is deeply entangled in this hormonal web too. Mast cells, which are the immune cells responsible for managing allergic responses, releasing histamine, triggering systemic inflammation, they actually have estrogen and progesterone receptors directly on their cell surfaces.
Wait, really? So if the mast cells are expressing hormone receptors, they are actively listening to and reacting to the reproductive endocrine system.
Exactly. And an overwhelming majority of hEDS patients suffer from a highly prevalent comorbidity, mast cell activation syndrome, or MCS.
Right, MCAS, where their mast cells are already hyperreactive, prone to degranulation at the slightest provocation.
Yes. This raises a profound clinical question. During the chaotic hormonal storm of perimenopause, with estrogen and progesterone spiking and crashing violently, are those hormones not merely loosening the joints but simultaneously triggering massive systemic mast cell degranulation?
Oh my goodness. We could be looking at a scenario where a significant percentage of the pain, the chronic inflammation, the crushing fatigue, and the neurological brain fog is actually an immune system flare-up, masquerading as pure structural joint pain.
Exactly. Are the erratic hormones aggravating the immune system, which in turn heavily inflames the already vulnerable connective tissue? Disentangling the mechanical failure from the immune response might be the next great frontier in managing hEDS.
That completely shifts the paradigm of how we view symptom management during this transition. That is wild.
It is.
And it's an entirely separate deep dive for another day. But it really reinforces the reality that when you navigate a connective tissue disorder, the traditional diagnostic models simply do not apply. You are navigating highly complex, interconnected systems, but at least the research is finally charting a clear path forward.
It absolutely is.
Well, thank you so much for joining us for this deep dive. We'll catch you next time.